Let's go ahead and get started. So let me introduce Dean Lloyd Minor. Dean Minor is the Dean of the Medical School at Stanford University. He graduated from, let's see, from Brown, was it? And then,
right.
There we go, from Brown, and then did his residency at the University of Chicago, and then a fellowship at the Neurotology group in Nashville. His early career was started at Johns Hopkins, where he became a dean of the department, and then later became a provost, and then took the job at Stanford. Most importantly for us today, he's going to talk about superior canal dehiscence that he actually discovered. At one time, it was actually known as Minor syndrome. And so, Lloyd, thanks for joining us today and coming out of your dean's hat and coming and joining us as neurotologists. We really appreciate it.
Well, thank you. It's great to be with you. And I think this is a brilliant idea to organize these conferences. So let me share my screen and let's see here. There we go. And share and then go back up here to, oops, got arranged out of order here, but we'll fix that. Okay, here we go. Well, I wanted to talk about superior canal dehiscence syndrome, but also really talk about the process that led to the discovery of the syndrome. And first, I want to say that since I sort of left the real world and went into various other forms of leadership in 2009 as provost at Johns Hopkins, and then 2012 moving here to Stanford to be dean of medicine, this work at Johns Hopkins has been carried out by John Carey. In fact, I'm going to talk a little bit about John's work that he did when I still had the privilege of working with him as a faculty member at Hopkins. John's done a superb job keeping the work moving forward and extended our knowledge of this syndrome in really important ways. So let me just also begin. Also, these are my disclosures of my relationships with industry, but none of the work I am going to be discussing today is related to any of these companies or the work that I do with them. So my interest in the vestibular system goes back a long way. Goes back to when I was an undergraduate, as Bill said, at Brown, and I took a bioengineering course that used mathematical models of physiological systems to show how, relatively straightforward math and what's called linear systems theory could be used to not only describe the way physiological systems worked, but really to understand them mechanistically and to be able to organize and interpret experiments surrounding those systems. And one of the examples used in the class was the vestibular system. And I read this paper and the two companion papers that accompany it, that really, these were papers that came out in the early 1970s. And I thought then and think today that the work was really incredibly beautiful. It's work done by Cesar Fernandez and Jay Goldberg at the University of Chicago. And each of us probably has had in our lives a time or experience where it was an epiphany. We sort of said, well, this is what I want to do, or this is where I want to focus my career moving forward. And for me, as an undergraduate, these papers sort of said, well, I would really like to pursue something related to the vestibular system later in life. And I knew I wanted to be a physician. And then as a medical student, I love surgical rotations. And of course, the way to combine them, interest in the vestibular system and surgery, is in our specialty of otolaryngology, head and neck surgery, and now our subspecialty of neurotology. So that's how things got started. And I spent a long time training, 11 years after medical school, 2 years in general surgery. That was back in the day when everybody going into otolaryngology did 2 years of general surgery. And then 4 years in the research lab of Jay Goldberg at University of Chicago, then 4 years as an otolaryngology resident. And then a year from 92 to 93 as a neurotology fellow with Mike Glasscock and Gary Jackson at the otology group in Nashville. And then I hit the ground ready to run in 1993 at Johns Hopkins. And really, that was the first time that I had the opportunity, beginning my faculty career at Hopkins was the first time that I had the opportunity really to put together a research focus and a clinical practice devoted to otology and neurotology, and then subsequently really focused on vestibular problems. So that's the background. Just a brief review. It'll be very brief because this is an informed audience, but we know that the inner ear, of course, has two parts, the vestibular system, the cochlea. I will point out that the vestibular system evolved long before the cochlea, long before hearing. The most primitive, the records of the most primitive vertebrates, the fossil records of the most primitive vertebrates show a labyrinthine structure that's not that dissimilar from ours. The most primitive extant vertebrates on Earth, which are lamprey and hagfish, fish that are at the bottom of the ocean. Lamprey and hagfish have a vestibular system, a labyrinth that's remarkably similar, except they only have two semicircular canals. So the system is phylogenetically very old, and it's had the benefit of millennia of evolution. As a result, under normal circumstances, of course, it functions quite well. And that, to me, has always been an elegance of studying the system because it is so highly evolved and is a great example of a physiological system that when it's working, it really is darn close to perfect in terms of what it does. One of the major reflexes controlled by the vestibular system, and certainly the most important reflex in terms of our clinical understanding of the vestibular system, is the vestibulo-ocular reflex. And this diagram shows you the way that works. In the cartoon, the subject's head is moving to the left and the eyes are moving back to the right in a compensatory way. So the vestibulo-ocular reflex is the reflex that enables us to maintain steady gaze during rapid head movement. So when we're jogging or riding a bicycle, the vestibulo-ocular reflex compensates for the motion of our head and enables our eyes to remain stable in space. In particular, enables the images of objects on the fovea to remain stable. The fovea is actually a very, very small part of the retina. It's the area, of course, where the photoreceptor cells and the optic nerve fibers are the most densely packed. And in order for us to have clear vision, we have to keep images stable on the fovea. In fact, if we didn't have a vestibulo-ocular reflex, there would have been no purpose for us to have ever evolved a fovea. So let me see here, go to the next slide. The other reason the vestibulo-ocular reflex is often talked about and studied is that it is probably the best understood reflex in the body. It's relatively simple in terms of its overall organization. They're vestibular nerve afferents that innervate the 5 vestibular end organs, the 3 semicircular canals, the 2 otolith organs. I've just shown here a representation of those afferents innervating the horizontal canal. Those afferent nerve fibers project to the vestibular nuclei in the brainstem, and then central vestibular neurons project to extraocular motor neurons, and those in turn innervate the eye muscles. Works in a push-pull reciprocal innervation fashion. So if you're moving your head, as shown in this diagram, to the left, then that's going to lead to activation of the agonist muscles that will cause the eyes to move to the right, and inhibition of the antagonist muscles that would tend to pull the eyes back to the left, as shown on this diagram. Now, the discovery of superior canal dehiscence really, I think, brings together 3 essential components of discovery and innovation. And I describe those as the 3 C's: combination, collaboration, and chance. And each of those 3 C's is manifested in the process that led to the description of superior canal dehiscence and the development of a surgical procedure to, in most cases, alleviate, if not eliminate, the symptoms and signs of the disorder. This came together really for me, and I've said many times, and I hope it's true for all of you, that the best teachers in my career have been my patients. And certainly superior canal dehiscence would not have ever been discovered, described without interactions with patients. It really dates back to the spring of 1995. As I said, I joined the faculty at Hopkins in September of 93. And in the spring of 95, a couple of patients came to see me with very similar complaints. And this was the first. The 54-year-old man with sound-induced vertigo and oscillopsia, oscillopsia being the apparent motion of objects that are known to be stationary. He had a sensation of motion when he heard loud noises in his right ear. He had fluttering vision, oscillopsia when he made whistling, trilling, or humming noises. He had no past history of otologic disease. His exam was really completely unremarkable. His Weber did lateralize to his right ear, and that's going to be significant, as we'll see in a moment. And he had eye movements evoked by sound in the right ear. And so this is an infrared video of this patient's eye movements. It's a bit grainy. It was 1995, but I said combination, collaboration, and chance. I think the chance element here is that seeing a lot of these patients back when I was very active as a neurotologist, and still seeing some superior canal dehiscence patients now in my current role and as a faculty member in otolaryngology at Stanford. These eye movements are the largest eye movements I've seen in any patient with superior canal dehiscence. And this was the first patient. I mean, frankly, oftentimes the eye movements are subtle, and sometimes patients don't have evoked eye movements, but these eye movements were really quite pronounced, as you'll see. So this is a 500 hertz tone to the right ear. And you can see that the eye is moving upward, and this is an IR infrared image of the right eye. The eye is moving up and in response to the sound. And when the tone stays on longer, the eye stays deviated, and then there's some fast phases of vestibular nystagmus in the opposite direction. So I hope you get the picture that those are huge eye movements, and they're temporally linked to the stimulus, and they're not random, right? I mean, the eye was moving, and by the way, they're conjugate. I was only showing the right eye, but the eye movements are conjugate between the two eyes. And the eye movements are exactly the eye movements you would expect from activation of the right superior canal. We've known the relationship between individual canals and the eye movements produced by stimulation of those canals for more than a century. That was all worked out in the late 1800s, the 1890s, in Vienna, the same place where Politzer really started our field of otology. And the right superior canal activation leads to exactly the eye movements you saw in that video, namely the slow phase components of the nystagmus are up, and the superior pole of the eye moves away from the stimulated ear, as shown in this cartoon diagram. Now, part of our ability to work out the mechanism here, first, it was clear when I first saw this, and others subsequently that examined this patient with me saw the same thing. It was clear that these eye movements were almost certainly coming from activation of the right superior canal. But our ability to really define that in greater detail, and in particular to study it in patients for whom the eye movements were much more subtle, that ability was enhanced through our ability to record the eye movements. And so often in biomedicine, advances are triggered by technology. Whether or not we're talking about fundamental discovery-based research or we're talking about clinical work. Our ability to measure things and to study them quantitatively dramatically enhances our ability to make discoveries. And that was the case for superior canal dehiscence syndrome, because thanks to work that had been done many decades ago by the late David Robinson, a professor of biomedical engineering and ophthalmology at Hopkins, the scleral search coil technique for recording three-dimensional eye movements was very much up and running there, and still is today, and forms the basis of a lot of what John Carey and David Z do in their research. The scleral search coil technique, although it's cumbersome, it doesn't really generalize, and now we have other eye movement recording techniques that offer comparable levels of accuracy. In the mid 1990s, the surgical technique was by far the gold standard. And it's shown here. There's a silastic annulus that has embedded with it a coil of wire. You can see the little lead coming off to the side there, and that fits around the cornea. And then as this coil of wire moves in an oscillating magnetic field shown in the aluminum structure that surrounds the subject, that sets up a small current in the coil of wire by Faraday's law, and that's accurately correlated with eye position. We use that technique then to study eye movements in these patients. And here's some of the findings. This is a patient with right superior canal dehiscence syndrome. The eye movements in 3 dimensions are displayed as torsion, or T, vertical, V, and horizontal. And you can see this is a torsional vertical nystagmus, right? There's not much of a horizontal component. Then we can calculate the axis of rotation for each of the slow phase components of the eye movements and map that axis of rotation on a sphere that represents the plane of the individual, or the axis of rotation defined by individual semicircular canals. Each one of the circles on this sphere represents an individual slow phase of the nystagmus. And what you can see is that the axis of rotation of the eye during the nystagmus is very precisely aligned with the axis of rotation defined by the right superior canal. So that's confirming what we saw visually, but now measured quantitatively. And that again was evidence that something was going on with the right superior canal. Well, what could be causing a person to have moderately loud sounds? That tone, by the way, that you heard was probably around 90, 95 dB. So these are more intense sounds, usually at the lower frequency. That was 500 hertz, and people who have sound invoked eye movements typically in the 500 to 1,000, maybe 1,500 hertz range. So what could cause sound to be activating the superior canal? Well, this is a cartoon animation developed by a very talented illustrator at the Art is Applied to Medicine department at Johns Hopkins. And it'll walk you through the mechanism. Won't be any surprise to any of you because you know how the ear works. But ordinarily, of course, sound travels as a traveling wave in the external canal to the tympanic membrane, through the ossicular chain, through the round window, and then around the cochlea, and through the oval window and around the cochlea and out the round window. Similarly, pressure as Valsalva against a pinched nostril can cause a similar motion of the stapes foot plate. And in the case of superior canal dehiscence, not only can sound or pressure travel around the cochlea, but this third bulbal window creates a pathway that allows the mechanical wave, the wave in the lymph, to flow not only through the cochlea, but also through the superior canal. And that's shown diagrammatically. So the effect of a dehiscence or opening in the bone overlying the superior canal then is to create a third mobile window into the inner ear, which allows sound to activate the vestibular receptors, causing the flow of endolymph and activating the superior canal. And furthermore, it's directionally specific, as you'll see in a moment. And that was really, I think, the most convincing evidence that this third mobile window hypothesis underlies the mechanism. Because as I'm showing diagrammatically here, let me back up just a second, and then you'll see it more clearly on the next slide. Oops, okay, sorry about that. Let's skip ahead here a bit. So not only can you have positive pressure from a Valsalva maneuver, but of course you can have, with insufflation and other, Valsalva against a closed glottis, you can get motion in the opposite direction. In other words, a flow of endolymph in the opposite direction, which should lead to an oppositely directed eye movement. And as I'll show you on the next animation, it actually does. So this is a this is a recording from the left eye, same IR video technique. And you're going to hear me say positive and negative. So what I have is a Siegel speculum in the left external canal, and I'm insufflating positive with positive pressure and then negative with negative pressure. And you're going to see that the eye moves in the same plane, but in the opposite direction. So positive pressure causes ampulofugal motion of endolymph in the superior canal, which is excitatory for the superior canal. And negative pressure causes ambulopedal movement of endolymph, which is inhibitory. And the eye moves in the same plane, but in the opposite direction. Okay, so let me play that. Now this is positive, negative, positive, negative, positive, negative, positive, negative, positive, negative, positive, negative, positive, negative. So that's the clearest evidence that I know of that, you know, the third mobile window hypothesis is the most likely explanation. I don't know of anything else that would cause the direction of the motion of the eye to go from always in the plane of the superior canal, but to go from excitatory to inhibitory. Now, those were important observations, but then really how do you get confirmation, of course, that there is an opening in the bone? And by the way, what was the first hint then that could be the mechanism, that it was an opening in the superior canal bone that could lead to this? Well, the first hint really was, remember I said back at the beginning of the talk that the discovery of the relationship between individual canals and eye movements produced by activation of those canals was made way back in the 1890s, okay? How was it made? Well, it was made by pigeons, taking pigeons, and pigeons are great for studies of the vestibular system or cochlea because they have a bulla, they have an air-containing space over the labyrinth. Sure would make our lives a lot easier as neurotologic surgeons if that was the case for us, but it's not. And what Ewald and other investigators did in the 1890s was to remove the bone from individual canals and show that then loud noises caused motion of the pigeon's eyes and head in the plane of that canal. But it was an opening in the bone that enabled them to do those experiments. So having some knowledge of that work from just studying the vestibular system and also other work related to canals and eye movements, that led me to suspect, you know, it was an opening in the bone that was leading to these problems. Then we worked with our colleagues in radiology, and this is where the collaboration part comes in. You know, in 1995, temporal bone CT was still pretty primitive. We got axial, coronal, and sagittal images, and then we kind of mentally reconstructed them in our mind. So we worked with radiologists at Hopkins, and also it was interesting. I gave a talk early on about this syndrome and showed axial, coronal, and sagittal images. And a person in the audience came up to me afterwards and said, you know, I think I can help you design some better algorithms for displaying your images with CT scans. This was a radiologist, his name was Noah Wegg, who was in private practice in New York State, but had an interest in CT and in algorithm development. And so we collaborated, and there's a paper in the journal Radiology that includes some Hopkins radiologists. But a lot of our initial CT studies were actually, before we got the algorithms implemented at Hopkins, a lot of the studies were done with Noah and his team. So collaboration in combination is really important in innovation. And of course, now all of this is second nature, and this is just showing a reformatted image of the superior canal, and then the solid yellow line is a plane shown on the right. And there you can see the cross section of the superior canal and the opening in the bone. Now, this comes with a lot of caveats. We know that you can miss a thin layer of bone on temporal bone CT, and John Carey has done some very elegant work in terms of near dehiscences and a lovely paper describing some of the physiologic effects of neurodehiscences, but I'll just focus today on sort of these clear-cut cases of dehiscence. And then you can get a family of reconstructed images here and sort of walk your way through and roughly calculate the length of the dehiscence of the superior canal. And of course, now we have the ability to do reformations in lots of different planes, including 3D reconstructions. But again, all of this involves volume averaging, and therefore you can miss a thin layer of bone the more reformatting and reconstructing that you do with the images. There are also, of course, characteristic audiometric findings associated with superior canal dehiscence, and these are shown on this slide and some of the following slides I'll show you in a moment. There typically is a low frequency air bone gap, and there oftentimes is this conductive hyperacusis for bone conducted sounds. That is, a better than 0 dB threshold for bone conducted sound, maybe at 250, 500 hertz, seeing a threshold of minus 10 dB or so. Now, it isn't always present, but when it is present, it's an indication to really be suspicious that that the person may have superior canal dehiscence syndrome. Another addition, which we started when I was still very active at Hopkins, but John Carey, Miriam Wilgum-Pola, and others have really carried forward in a brilliant way of vestibular evoked myogenic potentials, which are now, I think, in common use in neurotology practices across the country. And the finding there is that the threshold and the amplitude of cervical and ocular vimps, they have a lower threshold and higher amplitude in dehiscence than in non-dehiscence, which is, of course, also an indication of the third mobile window effect. And this just goes to show, this shows you some data from a study that Miriam Wilgum-Pola did when she was a fellow with us at Johns Hopkins. And what it shows is that preoperatively, you see a distinction between cervical vimps for those that have dehiscence, namely the amplitude is higher and the threshold is, pardon me, this is for amplitude for ocular and cervical vimps, so the amplitude is higher and also the threshold tends to be lower. And after, the other thing is that usually the vimp thresholds do return to normal after surgical correction of the dehiscence. And this is the amplitude data, again, showing that for the dehiscent superior canal, the thresholds are lower and the amplitudes tend to be higher. So when I'm giving this lecture and I can actually hear people, I ask the question. So I asked the question virtually today to all the neurotology fellows, just what are we looking at on this slide for the right ear at 2000 hertz? I'll tell you that this is a patient with superior canal dehiscence, and you see a large air bone gap at 2 kilohertz. And I hope you're all thinking Carhart's notch. And this goes to show that you can have a Carhart's notch in superior canal dehiscence. So it is not pathognomonic of otosclerosis. And frankly, this is the post-op. I show the pre-op values here and then the post-op values, and you can close that Carhart's notch with surgical correction of the dehiscence. Now, this patient also had a dehiscence on the other side, which is probably why we're still seeing negative bone conduction thresholds after surgical correction. I'm delighted that John House is on this, this Zoom conference today because John has written many, many high impact papers in our specialty, but one is particularly closely related to superior canal dehiscence. This is from John's paper in Laryngoscope in 1980, and John reviewed the House ear clinic experience with what was then described as inner ear conductive hearing loss. And he wrote very clearly and succinctly Inner ear conductive hearing loss is a term we have used to describe a situation in which there is a consistent conductive element in the hearing impairment, but no evidence of tympanic membrane or ossicular problem. He went on to write, this is 1980, remember, we do not have an explanation for this phenomenon, but suspect that there is some inner ear abnormality not visible on the polytome X-ray. And John, you were exactly right, because these cases.
But you figured it out.
But you presaged it and did it very eloquently. And what we found when we wrote about this syndrome first paper came out in 1998, and all of us, I think, as otologists, neurotologists, had seen patients like this, and they were real puzzles. And then we started bringing people back and saying, well, maybe you have this, and that, I think, added to the credibility, because if it had just been us in Baltimore finding this, I doubt many people outside of Baltimore would have cared. But the fact that the broader neurotology community could resonate with the finding and then actually discover it, I think added to the acceptance, and not only the acceptance, but the furthering of the understanding of the syndrome, because many, many people have contributed to that understanding. So there's an important point about this, and that is when you see an audiogram with an earbone gap, it's important to either get a VEMP response, or you can look at the reflex, because as we know, the acoustic reflex is absent very early on in otosclerosis, typically before you get much of an earbone gap. And if you have a 15, 20 dB earbone gap at low frequencies on an audiogram, and there is a robust acoustic reflex in that ear, that is almost certainly not otosclerosis. And that should prompt you to get some other testing to rule out or evaluate for superior canal dehiscence. VEMP thresholds can also be used in those patients, but the reflex provides a really good screening mechanism and is a part of most routine audiometry. Now, what's going on? What causes this? We spent a lot of time thinking about that, and John has certainly carried that. John Carey's carried that work forward. By the way, this goes to show you that I think you can see here the panel for the right ear. That's a Stapes prosthesis. This is a patient that was referred to us. He'd had a perfectly excellent technical stapedotomy by a very fine otologist, but his earbone gap wasn't closed, and his vestibular-induced symptoms actually became greater. I put this slide in not, well, to show you that example, but also notice, so this is the dehiscence in the superior canal, but look at the contralateral ear. The bone covering the contralateral superior canal is also thin. And that, plus this finding, and this, when John Carey was a fellow with us back in the day, John reviewed the temporal bone collection at Johns Hopkins, which has over 1,000 carefully archived specimens that fortunately were sectioned in a parasagittal plane rather than a horizontal plane, which was typical of the Mass Eye and Ear group. And in these parasagittal sections, of course, you get a lovely view of the bone covering the superior canal. And there are several different, as we know, as neurotology surgeons and working in the middle fossa, there's several different patterns of ossification and pneumatization at the arcuate eminence. There's some that have a number of air cells covering the superior canal, others where the bone is more dense and compact, still others in panel C where the bone is quite thin. And finally, and John found this, I think, in about 2% of the specimens, where there was a really very thin layer of bone, and perhaps even the bone was disrupted. We knew that this wasn't an artifact of fixation because you can still see the dura intact. And if this specimen had been damaged in fixation or sectioning, then the dura probably would have been disrupted as well. So that was an indication that, well, and when the bone was thin in one temporal bone, it was inevitably thin on the contralateral side as well. And then there were about 40 specimens in the Hopkins archive at various stages of gestation and for infants that had died for various causes. And what we found was that the bone overlying the superior canal, indeed the bone of the arcuate area itself, ossifies late. It ossifies postnatally. As you can see here at 10 months, there's still active 10 months of age, there's still active centers of ossification. And the bone does not achieve its adult thickness until about the age of 3 or 4 here on this slide. This is thickness of bone measured overlying the superior canal and then age. You really don't get to adult thickness until 3 or 4 years of age. So the hypothesis is that there's some problem in that ossification process. The bone covering the superior canal doesn't form normally. People then have a very thin layer of bone that later on in life can become disrupted and lead to the onset of symptoms. So it's a developmental abnormality. The other thing, the CT scan study confirmed the fact that there's a bilaterality to the process. This, by the way, the syndrome is bilateral in maybe a third of patients, 30% or a third of patients. And this shows you a patient in whom the syndrome, the dehiscence is bilateral. And even when it's not bilateral, the thickness of bone covering the contralateral superior canal is abnormally thin. So that's shown on, this is comparing the CT findings, thickness of bone over the normal superior canal at the peak of the arcuate eminence is about 0.7 millimeters. The thickness of bone contralateral to a dehiscent canal is 0.3, so very thinner. And that was borne out in the histological measurements that John made as well. So some sort of developmental problem that lays the framework for there later being a dehiscence. Now this next data is from the series that we compiled a number of years ago, over a decade ago, but the statistics I think have borne out even as more cases have been added. Roughly, it's 171, the first 171 patients we saw at Johns Hopkins, roughly equally divided among men and women, bilateral in 30% or so, and then right side and left side reflected here. A little bit of asymmetry here. I don't think that's borne out with subsequent increased numbers of cases. It seems to be relatively symmetric between the 2 years. The mean age at the time of diagnosis was 46, youngest was 13, the oldest was 78 at the time of diagnosis. But very few children in this series, even to this day. So generally, the time that symptoms and signs are starting to occur is in young adulthood. The symptoms: sound-induced vertigo in 60%, pressure-induced vertigo in half. This conductive hyperacusis, which by the way accounts for the lateralization of the Weber. And also there's this interesting sign that you can, if you take a 512 hertz fork and put it on the ankle, the lateral malleolus, oftentimes people will hear it in their affected ear. So again, a manifestation of conductive hyperacusis. Chronic disequilibrium, autophony in roughly half. And autophony can be the most disturbing symptom for many people, and pulsatile tinnitus in roughly a quarter. The other manifestation of this conductive hyperacusis is this bizarre symptom. And people, when you first hear about it from a patient, you think this is the weirdest thing I've ever heard, but it has a clear physiologic explanation. And that is, some people can hear their eye movements. It's like, what? But they can hear their eye movements. And if you think about it, the superior and inferior obliques are muscles that have a tendon, and that tendon travels through a fibrous band called the trochlea that anchors the tendon of the oblique muscle to the orbit. So that tendon moving against the orbital bone provides, in the setting of conductive hyperacusis, so in this hypersensitivity of bone conducted sound, the bone is being vibrated by the motion of the tendon. And that provides a likely explanation as to why people have this bizarre symptom of hearing their eye movements when it does occur. The signs: sound-induced eye movements in 58%. You can actually get a head tilt, a movement of the head in the plane of the superior canal in a minority of cases. Valsalva-induced eye movements, as I showed you, and also external auditory canal-induced eye movements. Now, for many people, including that first patient whom I described to you today, just the explanation of what's going on is enough. They don't need any further treatment. And indeed, I don't think any of us would offer surgery to a person who says, well, you know, it's a little disturbing, but I can live with it. I mean, we have no evidence that this syndrome causes a long-term threat to hearing or balance. And the indications for surgery, therefore, should always be the debilitating nature of the symptoms. And for the first patient, to my knowledge, he's never had the problem corrected. I kept in touch with him for maybe 10 years or so. He was doing fine. As I described to you, he experienced symptoms when he sang in the shower, and he stopped singing in the shower, and stopped going to, you know, settings where he was around a lot of loud noises. But other than that, his symptoms were never that debilitating. But other patients, the symptoms have been very debilitating. And oftentimes, the most debilitating symptoms are some of the following. There's a minority of patients, as I said, who experience pulsatile oscillopsia. That is, they actually have unstable vision, usually in phase or in time with the venous pulse pressure. And recall that in many people, the superior pterygoid sinus travels just over the arcuate eminence. And for some people, that's probably the mechanism of this, this pulsatile oscillopsia. So that is really, really, really debilitating. You know, imagine things are moving just a little bit when you're trying to read, when you're trying to go to the grocery store and do shopping. So that can be very debilitating. Autophony can be debilitating. Sometimes the sound-induced motion of the eyes is so severe that people can't, you know, you can't avoid all noises unless you lock yourself in a room. So those are the symptoms that oftentimes lead people to seek surgery. When I was thinking about how to go about this surgery, I'm going to describe the way the technique we developed at Hopkins. There are many, many, many different ways to do this surgery. I approached these cases through the middle fossa because I felt comfortable with the middle fossa approach. I also felt like it gave me as a surgeon the best visualization of the superior canal. Certainly for many of these cases, you can approach it through a transmastoid approach, and that has become more and more common, and that's great. I'm not saying anything against it. But I'm going to describe the way we developed it and the way I think in many cases it's still being done, but there for sure are more than one way to do this procedure, just as there's more than one way to do almost everything we do in otology and neurotology. Again, this is a cartoon animation, and then I'll show some surgical videos. We, early on, when image navigation started coming out, we started using image navigation because we felt like it helped us locate our craniotomy more accurately, make a smaller craniotomy. And so these are the fiducial markers that are placed on the skull prior to then referencing those markers and putting in place a post that's used to reference during the procedure. Sort of a standard middle fossa incision, and then harvesting some temporalis fascia. And there we see the House urban retractor. Then this is maybe a 3 centimeter craniotomy, and then putting in the retractor, and then looking down at the floor of the middle fossa. Now, as we know, as neurotologists, unfortunately, it's not color-coded like this nice artist depiction, but you still get the idea of the superior canal. And this just shows you a coronal image then with the labyrinth and the dura retracted and the various landmarks. The other thing about this is that the dura, the tegmen tympani and tegmen mastoideum are very frequently dehiscent as well. We see very few frankencephaloceles, but the floor of the middle fossa looks very, if you will, moth-eaten in many of these cases, which can make finding the superior canal a bit of a challenge and finding the dehiscence a bit of a challenge. That's just the artist's rendition there. This is then a close-up view, and the technique that we developed involves plugging the canal, and we're feeding in some fascia here, as you'll see, both anteriorly and posteriorly through the dehiscence to compress the membranous canal. And then we're going to add some bone chips there to also compress the membranous canal and hold the fascia in place. And then obviously you have to do it in both directions and then cap off the dehiscence itself. And that shows you a side view of what the dehiscence repair looks like. Then we put everything back together again, placing the bone flap and then closing things up. So that's the middle fossa approach as we've developed it. And again, others can make modifications for sure. This is then an image looking through the optic microscope at the floor of the middle fossa at a typical dehiscence. And then the next, this is a operative video. This shows you, this is about a 4mm dehiscence. Again, the dehiscence is, you can see the beefy appearance of the membranous canal compared to the pearly white appearance of the arc of eminence and petrous portion of the temporal bone. And then we'll be packing in some fascia in both directions. The other thing that when you're doing the surgery that's reassuring is that when you're packing the fascia, if the fascia pooches out from the other end, that tells you you've got a closed system and you're probably in the superior canal. I mean, there are obviously other ways of telling it as well. And then we're using some bone chips to hold the fascia in place. And then ultimately that'll get capped off with some bone covering the dehiscence itself. So, yeah, there we are, finishing that. So how do we know that we're doing what we say we're doing? And by the way, when I was thinking about, well, what can we do to help these very debilitated patients? And we could certainly have done a vestibular nerve section, but that seemed like a radically destructive procedure. And by plugging the canal, we reasoned that, well, we would certainly diminish function in that canal. And I'll talk about resurfacing in just a moment. We would certainly diminish function in that canal, the superior canal, but we should be able to preserve the function in the horizontal and posterior canals. And that's what is done most of the time. We now, at the time, we were using 3-dimensional eye movement recordings, a surgical technique. Now you can do it with video recording techniques, and that is move the head rapidly in the plane of each of the semicircular canals in an excitatory direction for that canal, and then measure the eye movements, the vestibulo-ocular reflex, in response to the head movement. We've inverted the eye movements so it looks like the eye and the head are moving in the same direction, but we've inverted them so you can actually compare them. And of course, if the vestibulo-ocular reflex is working properly, then the eye and the head movements ought to be the same amplitude, but in opposite direction. And that's what's going on here. Again, the head velocities in green and left eye and right eye are in blue and red respectively. You can see that even before the surgery, there's a little bit of dysfunction in the superior canal in the affected ear. And then after the surgery, again, the horizontal and posterior canal function is preserved. The superior canal function is markedly diminished, thereby providing evidence that in most cases, selective plugging of the superior canal preserves function in the other two canals. So it's a far less destructive procedure than is a nerve section. This is probably a good point in time to mention something about resurfacing. I did early on try a couple of cases with resurfacing and found that people recurred with their symptoms, and so we went back to plugging. It was a technique we felt comfortable with. I think others have also seen that there's a higher rate of recurrence with resurfacing. That may be because it's just hard at the arc of eminence to get a resurfaced substance or plug or covering that stays in place. But at any rate, the plugging does offer, I think, a more definitive correction. Yeah, and so I think that's those are that's the end of my slides. And I would welcome any feedback or questions. And maybe first I should ask the person who's actually continuing to do this on a regular basis, John Carey. John, if you have any comments or things to add or corrections of anything that I've gotten wrong in my rustiness of being away from this for a while. John?
Thanks, Lloyd. That was great. It's always fun to get the tour again. And I always enjoy hearing the story of that first patient. We had a lot of fun patients together. And I think, yeah, you know, this is a magnificent addition to neurotology that you and Dave Z and the other colleagues made. And this is certainly something that animates my practice every day, and I think has really given vestibular care a boost in otolaryngology and neurotology and otology. No, I don't have any other things to add. I think that yeah, the surgery's evolved in some ways, but you know, as Lloyd said, I think the essential thing is restoring that high impedance of the labyrinth. And you know, Lloyd, you taught me that to think about this is the hardest bone in the body, and it really has to be to keep sound flowing from oval window to round window and not going astray. And whatever we do to fix superior canal dehiscence, it has to respect that principle. It has to restore that high impedance. So, you know, we tried with resurfacing, but we didn't find that as reliable as a plugging plus resurfacing when that option's available.
We have a few minutes left. If there are other questions or comments, I would certainly welcome them.
That was an outstanding presentation. Thank you very much. It always comes up occasionally. I'll see one of our fellows or someone says that anytime they see an otosclerosis patient, they want to do a CT scan. I don't subscribe to that. Do you have any comments?
No, definitely not. We mentioned that, look, the reflex response should be absent in otosclerosis. You know, there are other things, other signs as well. If you're suspicious getting a VIMP, the VIMP response will also be absent in otosclerosis very early. I think if you have those indications, an absent reflex, probably an absent reflex alone. I turn to John Carey, but John, in your experience, you see a patient with a classic, conductive hearing loss, who has an absent acoustic reflex, who has no sound-induced symptoms or any other symptoms that might make you suspicious of SCD. Would you want to do anything more than verifying that the reflex is absent before you did a middle ear exploration and possible stapedotomy, or do you feel comfortable with just that evidence moving forward?
I typically be comfortable with that evidence. I think, you know, the conductive hearing loss in severe canal dehiscence is unique. It's really a conductive hyperacusis. Mm-hmm. And it's pretty rare that that they just have conductive hearing loss. They'll usually tell you, if you ask them, that they hear some internal body sound or some bone conduction. You know, one telling thing is that the patient who complains of substrate sounds, they hear air movers in the building, or they hear other people nearby through whatever seating they're on. One of the strangest complaints Lloyd and I ever heard was a patient who said they stopped going to church because they heard everybody else's bowels moving in the pew.
Yeah.
So it's rarely just superior. It's rarely just conductive hearing loss. It's also always look for that negative bone conduction. You know, one thing we learned in talking to our audiologists, you got to be careful. A lot of the services that calibrate audiometers may not calibrate below 0 dB HL. Why should they? You know, before this, there was no reason to test for it. So sometimes if you get your audiometers properly calibrated, you'll find that you bring these people back and it's actually negative 20 dB. Remember, it's a logarithmic scale normalized to the population. It's not a sound pressure level scale. So yeah, I mean, I think if you get an audiogram that shows an absent acoustic reflex and they don't have any of those other findings, I wouldn't get a CT in every circumstance. One caveat is, you know, always remember the absence of evidence is not necessarily evidence of absence. It's always reassuring if they've got an intact acoustic reflex on the contralateral side, just to make sure everything's working.